Hello, this is Mustafa Abdrabbu, and today we will discuss what is Wolf Parkinson White syndrome or WPW syndrome. So, Wolf Parkinson White syndrome is a syndrome of accessory pathway. What happens in this accessory pathway? We will go for what happens normally. What happens normally is a pulse. When a pulse is generated from the SA node, it goes to activate the atria, then to be conducted through the AV bundle and the AV node and to the ventricles. What happens in the Wolf Parkinson White syndrome is that we have an aberrant accessory pathway here. So instead of the impulse going only through the normal conductive pathway, it goes through the accessory pathway early and activates part of the myocardium. This is responsible for what we call the delta wave, and this, as it goes early to the accessory pathway and bypasses the physiological delay in the AV node, it leads to shorter PR interval, and the addition of the delta wave to the QRS complexes leads to a wider QRS. This can be memorized easily by going back to the name. So for Wolf, this is a wave called delta, and the other W is wide QRS, and the P, as you know, is short PR interval. Okay, so Wolf for a wave called delta, P is short PR interval, W is for wide QRS. So what is important with this? It can be a very benign disease. This is a simple ECG, a sample of ECGs. This is short PR. This is a delta wave, and this is a wide QRS, and it is usually associated with some repolarization abnormality and T wave changes. So what is the problem with activation of a small part of the ventricle early? Usually it is a benign. However, it can lead to life-threatening arrhythmia. This is what we call pre-excited AF. Pre-excited, because it is through an early excited accessory pathway. When conduction goes through the accessory pathway, then the AV bundle or AV node can become malfunctioning, and the whole fibrillatory waves becomes transmitted to the ventricle or conducted to the ventricle. This can achieve a very high heart rate and can lead to hemodynamic disturbance. An important thing to remember if you have a patient with pre-excited AF, that you cannot, and remember, you cannot never block the AV node. V node. How do we block the AV node? This is Valsalva, beta blockers, calcium channel blockers, Lanoxin. All of this should not be done. This is wrong. So what we do? We go for direct current cardioversion. So it is important to recognize this pattern, and if the patient had it, he should go and follow up with an electrophysiologist. Thank you.